Welcome. In this session and the next, we'll be discussing about posterior segment manifestations of ocular trauma, and in this session we'll be discussing about direct ocular trauma, both open globe and closed globe injuries, and in the next session we'll be discussing about ocular manifestations from distant trauma, also known as indirect ocular trauma, and photic or light induced ocular injuries. We'll discuss about anterior segment manifestations of ocular trauma in the cornea section later. Worldwide, ocular trauma is the most common cause of visual impairment in the age group 18 to 39 years, and ocular injuries can be broadly classified into direct ocular trauma, in which the causative agent comes in contact with the globe, and indirect ocular trauma, in which the eye is affected from an injury occurring at a distant non-ocular site. As we have mentioned, we'll be discussing about direct ocular trauma in this session and about indirect ocular trauma in the next. The Birmingham Eye Trauma Terminology System, or BETTS, previously known as International Society on Ocular Trauma, or ISOT terminology, classified direct ocular trauma as either closed globe injury or open globe injury. Closed globe injury is defined as one in which there is no full thickness defect in the eye wall, the eye wall being made up of the cornea and the sclera. Closed globe injury is further subclassified as contusion, in which there is no break whatsoever in the eye wall, either full thickness or partial thickness, and contusion occurs generally from injury with a blunt object, as shown here in this diagram. Lamellar laceration, in which there is partial thickness defect of the eye wall, as seen here in this diagram, which generally occurs from injury with a sharp object, and superficial foreign body, as seen here in this diagram. Open globe injury is one in which there is a full thickness defect in the eye wall, and open globe injuries are further subclassified as rupture when it occurs due to impact with a blunt object, and laceration when it occurs due to impact with a sharp object. During a rupture, the break or the full thickness defect in the eye wall occurs by an inside-out mechanism due to sudden severe increase in intraocular pressure at the time of the impact with the blunt object, and the full thickness defect in a rupture usually occurs at zones of weaknesses in the eye wall, such as the limbus, particularly at sites of previous ocular surgery, and parallel and posterior to rectus muscle insertion, where the sclera is thinnest, which is very important to remember. So in a globe rupture, the site of the full thickness defect may not correlate with the site of the impact with the blunt object. Laceration is defined as a full thickness defect in the eye wall caused by impact with a sharp object, and during a laceration, the full thickness defect in the eye wall occurs by an outside-in mechanism at the site of the impact. Lacerations are further subclassified as a penetrating injury in which there is only an entrance wound in the eye wall, intraocular foreign body in which there is a retained foreign object along with its entrance wound in the eye wall, and perforating injury in which there is both an entrance wound and an exit wound in the eye wall. The Ocular Trauma Classification Group, and not BETTS, also classified the zones of injury based on the posterior-most extent of the injury for both open globe and closed globe injuries separately. In Zone 1 open globe injury, the posterior-most extent of the full thickness defect is at or anterior to the limbus, as represented by the green area in this diagram. In Zone 2 open globe injury, the posterior-most extent of the full thickness defect is in the region of the sclera within 5 mm posterior to the limbus, as shown by the blue zone in this diagram. And in Zone 3 open globe injury, the posterior-most extent of the full thickness defect involves portion of the sclera more than 5 mm posterior to the limbus, as represented by the red zones in this diagram. In Zone 1 and Zone 2 open globe injuries, the retina is unlikely to be involved, but in Zone 3 open globe injury, the retina is likely to be involved because the average distance of the ora serrata from the limbus is between 6 to 7 mm, and this is very important to remember. Among closed globe injuries, Zone 1 closed globe injuries involve conjunctiva, cornea, and or the sclera, as represented by the green zone in this diagram. Zone 2 closed globe injuries involve the lens, zonules, and or the pars plicata, as represented by the blue zone in this diagram, and zone 3 closed globe injuries involve pars plana, choroid, retina, optic nerve, and or the vitreous body as represented by the red zone in this diagram. Evaluation of a patient with ocular trauma is primarily aimed at determining whether the injury is open globe or closed globe in nature and whether an intraocular foreign body is present in case of an open globe injury. But during the initial evaluation, it may not always be possible to definitively determine whether an open globe injury is present or not, either because of conflicting clinical signs or because of inability to perform thorough examination, and in this situation, exploration under general anesthesia is required to confirm or rule out an open globe injury. And it is very important to remember that stabilization of vitals in patients with polytrauma takes precedence over evaluation for possible ocular trauma, and these are very important points to remember. History taking is very important in a patient with ocular trauma, and as detailed information as possible should be taken about time elapsed since injury, the mechanism of injury, particularly regarding the force of impact, the agent involved and its material, whether the injury was due to heavy and or sharp objects during metal on metal impact, such as when working with hammer and chisel, or due to projectile from machinery, whether the injury can be contaminated, increasing the risk of endophthalmitis, and the potential for non-ocular effects of injury such as subdural hematoma in elderly patients following a fall. Other salient points which need to be noted during history taking in a patient with ocular trauma include previous ocular history, particularly previous eye surgery, use of spectacles or protective eyewear during the injury, presence of other non-ocular injuries, systemic history regarding anticoagulant use, drug allergies and comorbidities, and whether emergency measures have already been taken, such as tetanus toxoid and systemic antibiotic administration, and NPO status for general anesthesia. Examination of an eye with ocular trauma should be done with care by avoiding excessive ocular manipulation to prevent expulsion or further expulsion of intraocular contents, and an attempt should be made to assess the visual acuity and pupillary reactions, and to perform slit lamp examination and ophthalmoscopy if media clarity allows, to determine the presence of intraocular foreign body, vitreous hemorrhage, retinal detachment, and choroidal hemorrhage. Intraocular pressure measurement, scleral depression for peripheral retinal evaluation, and ocular movement examination should be avoided in open globe injury, and this is important to remember. Signs suggesting an open globe injury is very important to look for during the initial ocular evaluation, but absence of any or all of these signs do not rule out an open globe injury. These signs include diffuse and severe conjunctival chemosis and or hemorrhage as seen here in this clinical photograph, abnormal or uneven anterior chamber depth as seen here in this clinical photograph, with the anterior chamber depth usually being shallower than normal with an anterior full thickness defect, and usually deeper than normal with a posterior full thickness defect, distortion of pupil due to dragging of the iris towards the wound site, an iris hole as seen here in this clinical photograph which suggests entrance of an intraocular foreign body, prolapse of intraocular contents as seen here in this clinical photograph, lens rupture and or lens opacification early after trauma, vitreous strands towards a suspected or possible wound site, an intraocular foreign body in the anterior or posterior segment as seen here in this intraoperative photograph, endophthalmitis, an entrance wound as seen here in this clinical photograph, and usually a low intraocular pressure. And signs suggesting the following are very important to examine for: endophthalmitis, intraocular foreign body, retinal detachment, and choroidal hemorrhage as seen here in this clinical photograph. The two most important investigations for patients with ocular trauma are CT scan of orbit and B-scan ultrasonography. CT scan of orbit, which is done without contrast in patients with ocular trauma, can detect radiopaque foreign body made of either metal, stone or glass as seen here in this CT scan. And CT scan of orbit is considered as the imaging modality of choice to detect radiopaque intraocular foreign body and should be performed whenever intraocular foreign bodies are suspected. CT scan can also suggest scleral laceration or rupture by demonstrating flattening of the posterior contour of the sclera as seen here in this CT scan, which is also known as the flat tire sign, and CT scan of orbit can also show associated orbital fractures. In suspected open globe injury, B-scan ultrasonography should be done very gently through closed eyelids with copious amounts of ultrasound gel to avoid expulsion of intraocular contents. And B-scan ultrasonography is particularly important for eyes with mediopacification due to corneal clouding, hyphema, cataract, and or vitreous hemorrhage. B-scan ultrasonography is used to detect intraocular foreign body, particularly non-radiopaque intraocular foreign bodies made of plastic, wood or graphite which escape detection on CT scan or X-ray. The intraocular foreign body appears highly echogenic on ultrasound as seen here in these two ultrasound images, and so can be detected with very low gain. We have discussed about gain in ultrasound in the session on ultrasonography. Reverberation of sound waves between the anterior and the posterior surfaces of the intraocular foreign body can cause several echoes to appear on the B scan posterior to the intraocular foreign body as seen here in this USG image, and this is called ringing or comet tail artifact. In this image, the ringing artifact is seen posterior to the globe because the intraocular foreign body is located posteriorly within the globe, but the ringing artifact may be seen within the globe if the intraocular foreign body is located much more anteriorly. But if ringing artifact does not occur, an intraocular foreign body typically shows a shadow posterior to itself. B-scan ultrasonography can also show signs of scleral rupture such as vitreous incarceration at the injury site or intraocular air, retinal detachment as seen here in this ultrasound image, choroidal hemorrhage as seen here in this image, and vitreous hemorrhage and exudates which may be difficult to distinguish as seen here in this USG image. Magnetic resonance imaging can be done only after presence of a ferromagnetic intraocular foreign body has been ruled out, and this is extremely important to remember. Ferromagnetic intraocular foreign bodies move inside the eye during MRI and thus can induce further intraocular damage. CT scan is preferred over magnetic resonance imaging when the material of the suspected intraocular foreign body cannot be definitively determined. So MRI is rarely performed following ocular trauma but can be used to precisely delineate detailed anatomy of the injured eye and detect non-radiopaque intraocular foreign bodies and precisely locate them. Documenting history and all clinical findings prior to any intervention is extremely important for medical legal purposes. Following direct open globe posterior segment trauma, any wound healing response in the retina, though similar to that elsewhere in the body, causes anatomical and functional compromise much more severe than elsewhere in the body. In open globe injuries, without treatment, limbal or scleral rupture or laceration close by fibrovascular proliferation from the episclera external to the sclera and from the choroid or ciliary body internal to the sclera within 5 to 7 days and matures by 4 to 6 weeks, and this is much faster than healing of corneal lacerations, which takes months. Also, during the direct ocular trauma, the mechanical impact itself can detach the posterior vitreous cortex. Following posterior segment open globe injury, vitreous incarceration at the site of the full thickness defect in the eye wall as shown here in this diagram, and fibrocellular proliferation on this vitreous scaffold can lead to proliferative vitreoretinopathy and traction retinal detachment, and this is why early vitrectomy is recommended following posterior segment open globe injury, as we will be discussing further in this session. And this fibrocellular proliferation is promoted by vitreous hemorrhage, intraocular migration of inflammatory cells, transdifferentiation of RP and glial cells, which we have discussed in the session on proliferative vitreoretinopathy, and proliferation of microglial cells. Open globe injuries require urgent closure of the full thickness defect in the eye wall, and while waiting for surgery, a shield should be applied over the injured eye for protection till surgical repair is carried out, Tetanus toxoid administered if the patient has not already received it following the injury. Systemic antibiotics initiated, preferably 4th generation fluoroquinolones such as moxifloxacin, which attain adequate intravitreal concentration following systemic administration, and maintenance of NPO status for general anesthesia. And these are very important points to remember. It is also to be noted that prior to surgical repair, topical application of eye drops is not recommended in eyes with open globe injury because preservatives are known to be toxic in the intraocular environment. Primary closure of the wound should preferably be done under general anesthesia, and pedibulbar anesthesia for this purpose should be avoided, as pedibulbar anesthesia can increase intraocular pressure, leading to expulsion of intraocular contents through the wound. Procedures indicated or recommended during primary repair include removal of lens matter in injured eyes with rupture of lens capsule, and some recommend administration of intravitreal antibiotics during primary repair to reduce the risk of endophthalmitis, as well as vitrectomy if media clarity permits for intraocular foreign body removal, and to reduce the risk of proliferative vitreoretinopathy. Following primary repair of the wound, secondary surgical procedures may be indicated for intraocular foreign body, cataract, hyphema, vitreous hemorrhage, choroidal hemorrhage, retinal detachment, and endophthalmitis. Management principles of ocular trauma also include visual rehabilitation of injured eyes with good visual potential, particularly therapy to correct amblyopia in children, protective eyewear to reduce the risk of further ocular injury in future in either the injured eye or in its fellow eye, and psychological support. Full thickness scleral injuries can be either scleral rupture occurring following severe blunt injury, and which, as we have discussed, most commonly occur at the limbus, or parallel and posterior to rectus muscle insertions, penetrating scleral laceration following injury with sharp objects or projectiles, and perforating scleral laceration following injury with high velocity projectiles or sharp objects. Clinical features suggesting scleral laceration are severe conjunctival chemosis and hemorrhage, deep anterior chamber, low intraocular pressure, restricted ocular ductions, severe vitreous hemorrhage, and expulsion of intraocular contents. As we have already mentioned, ocular ductions are preferably not examined for following a suspected open globe injury. As we have mentioned, management of full thickness scleral injury is urgent primary closure of the scleral wound and associated corneal wound if any under microscope control, and preferably under general anesthesia. If full thickness scleral injury is evident or suspected, an adequate peritomy, often 360 degrees, with sharp dissection of tenon and conjunctiva from the sclera in all 4 quadrants is performed to expose the full extent of the wound as shown here in this diagram. This exploration of sclera should be continued till and behind the level of rectus muscle insertion to determine the posterior extent of the wound or to locate posterior wounds. Detachment of rectus muscles from their insertions may be required, followed by scleral repair, and then reattachment of the detached muscles back to their original insertions. Exploration further posteriorly is not recommended, as maneuvers required for repairing far posterior wounds may induce expulsion of intraocular contents, and these wounds are left to heal by themselves by fibrovascular proliferation, as we have discussed. The scleral wound is closed with interrupted 70 or 80 polygalectin sutures on a spatulated needle as shown here in this diagram, and the sutures are placed closely, starting anteriorly and progressing posteriorly. If there is a corneoscleral laceration, the limbus is first sutured, followed by the cornea and then the sclera, and this is very important to remember. Prolapsed vitreous, as shown in green in this diagram, should be excised without traction to reduce the risk of vitreous incarceration in the sutured wound. On the other hand, prolapsed uveal tissue and retina should be reposited, but occasionally they may need to be excised if they appear devitalized, and if there is significant loss of scleral tissue, a scleral patch graft will be required to close the wound. As we have mentioned, significant intraocular manipulations such as anterior chamber wash, removal of cataract and IOL placement are deferred to a second procedure. But in case of a ruptured anterior capsule, removal of lens matter should be performed during primary repair, with IOL placement being deferred to a second procedure. Prophylaxis of endophthalmitis during primary repair includes, as we have mentioned, systemic administration of fourth-generation fluoroquinolones such as moxifloxacin, but some also advocate intravitreal antibiotic administration if the media is clear and there are no contraindications such as retinal and or choroidal detachments. Some also advocate prophylaxis of retinal detachment during primary repair, such as prophylactic scleral buckling in eyes with scleral laceration 5 mm or more posterior to the limbus, or vitrectomy, as we will be discussing next. Early vitrectomy within 14 days of a posterior segment open globe injury has been shown to reduce the incidence of poor vision, anthysis and or enucleation, and so early vitrectomy is recommended for all eyes with scleral laceration having moderate to dense vitreous hemorrhage and visual acuity of light perception or worse. Goals of vitrectomy include clearing mediopacification from lens matter and or vitreous hemorrhage, removing incarcerated vitreous from scleral wound and inducing posterior vitreous detachment as shown here in this diagram, and treating any associated pathology such as retinal breaks, retinal detachment and intraocular foreign body. In addition to moderate to severe vitreous hemorrhage and incarcerated vitreous in the scleral wound, both of which occur in a high proportion of eyes with posterior segment open globe injury, indications of vitrectomy also include intraocular foreign body, phacoanaphylactic uveitis, raised intraocular pressure not controlled by medications, retinal detachment, and post-traumatic endophthalmitis. Additional surgical procedures during vitrectomy include transection of fibrous proliferation at the exit site in perforating injuries, with the exit site usually being left unrepaired at the time of primary repair because of its posterior location, and chorioretinectomy in eyes with uveal and or retinal incarceration in the scleral wound as shown here in this diagram, and in eyes with poor visualization to perform vitrectomy following repair of an irregular corneal laceration. The opaque cornea can be excised. A temporary keratoprosthesis, as seen here in this clinical photograph, can be positioned in place of the removed cornea. Vitrectomy performed by visualization through this temporary keratoprosthesis, followed by replacement of the temporary keratoprosthesis with a full thickness corneal graft. The irregular iris remnants in this clinical photograph suggests a preoperative adherent leukoma. Timing of this early vitrectomy can be immediate during the primary repair or immediately after the primary repair, or delayed between 5 to 14 days following the injury, and most prefer delaying vitrectomy after primary closure of the wound achieves a watertight globe with restoration of intraocular pressure. Benefits of delaying vitrectomy include better visualization following reduction of corneal edema if any, reduced risk of intraoperative hemorrhage, spontaneous separation of the posterior vitreous cortex from the retina, allowing time for closure of a posterior unsutured wound, and allowing time for diagnostic procedures for preoperative assessment of ocular status and prognosis. Ideal time for delayed vitrectomy is controversial, but should be after 5 days if there is a posterior unrepaired wound and before 2 weeks to minimize proliferative vitreoretinopathy. Prior to this vitrectomy, ultrasound B scan is required to rule out retinal detachment and choroidal detachment or hemorrhage, which influence the positioning of the ports and the choice of the cannulas. Some advocate immediate vitrectomy during or within 72 hours of primary repair to reduce the risk of proliferative vitreoretinopathy, but separation of an attached posterior vitreous cortex from retina is difficult in eyes of children and young adults, particularly in eyes with retinal breaks and retinal detachments. Adverse effects of retained intraocular foreign body depends on the direct damage caused by the foreign body during penetration into the eye, such as iris tear, cataract and retinal break, sterility of the intraocular foreign body, and it is very important to remember that an intraocular foreign body significantly increases the risk of endophthalmitis, particularly that associated with Bacillus cereus, which causes fulminant endophthalmitis, and the risk of endophthalmitis is higher with a non-metallic or organic intraocular foreign body. On the other hand, high-velocity projectiles, because of their higher temperatures, have a reduced risk of causing endophthalmitis, and chemical composition of the intraocular foreign body, which may induce an inflammatory reaction which can cause proliferative vitreoretinopathy, epiretinal membrane, traction retinal detachment, and phthisis bulbi. Inert materials are well tolerated inside the eye if they have not caused endophthalmitis, and these intraocular foreign bodies include those made up of glass, plastic, sand, stone, porcelain, and even eyelash. And if intraocular foreign body made of these materials is detected several days following injury without causing endophthalmitis and without obstructing vision, they may be observed instead of prompt removal. On the other hand, metals cause toxicity called metallosis due to oxidation and other chemical reactions involving the metal ions, and this is very important to remember. Zinc and aluminium usually cause mild inflammatory reaction within the eye, but copper and iron are toxic to the retina and cause severe damage. Chalcosis refers to toxicity due to copper containing intraocular foreign bodies, and intraocular foreign bodies made of pure copper, such as a copper wire, cause acute chalcosis, in which there is a very severe intraocular inflammation which may lead to loss of the eye within a few hours, and these intraocular foreign bodies need to be removed urgently. On the other hand, intraocular foreign bodies containing less than 85% copper, such as those made of brass or bronze, can cause chronic chalcosis, whose signs include greenish-brown deposits on Descemet's membrane near limbus, resembling cave ring of Wilson's disease, as seen here in this clinical photograph, greenish aqueous particles, greenish discoloration of iris, sunflower cataract, as seen here in this clinical photograph, in which there is a petal-shaped deposition of yellow or brown pigment on the anterior lens capsule, brownish red vitreous opacities and strands, as seen here in this clinical photograph, and refractile metallic flakes on retinal vessels and internal limiting membrane in the macular region, as seen here in this clinical photograph. Siderosis refers to toxicity due to a retained iron intraocular foreign body, and iron has affinity for neuroepithelial tissues and gets deposited in the iris sphincter and dilator muscles, lens epithelium, trabecular meshwork, non-pigmented ciliary epithelium, and the retina and the retinal pigment epithelium, which are particularly prone to iron toxicity. Clinical features of siderosis include nyctalopia and decreased vision, constricted visual fields, rust-colored discoloration of corneal stroma, as seen here in this clinical photograph, heterochromia iridis, which refers to different coloration of iris in the two eyes of a patient, mydriasis, also called iron mydriasis, as seen here in this clinical photograph, poor pupillary reaction, brown deposits on anterior lens capsule, as seen here in this clinical photograph, and cataract, vitreous opacities, secondary open-angle glaucoma, early peripheral and late diffuse pigmentary changes in the retina, which is very important to remember, attenuated retinal vessels, and optic disc pallor. In addition to CT scan and B-scan ultrasonography to detect the intraocular foreign body, electroretinogram early after onset of siderosis shows increased amplitude of A waves with normal B wave amplitudes, also called a supernormal ERG, but over time the B wave amplitude diminishes and eventually the electroretinogram becomes extinguished in an eye with siderosis. As we have mentioned, an intraocular foreign body may be detected clinically if media clarity permits. Otherwise, if its presence is suspected, it must be ruled out by imaging such as CT scan and B-scan ultrasonography. Most intraocular foreign bodies require removal, and surgical planning requires consideration about location, visualization, size, shape and nature, and encapsulation of the intraocular foreign body. During the surgical procedure for removal of an intraocular foreign body, the intraocular foreign body needs to be completely freed from its adhesions with surrounding normal and abnormal tissues and mobilized before extraction. Then it can be removed with the help of a magnet for a ferromagnetic intraocular foreign body or with forceps, as seen here in this intraoperative photograph. Small intraocular foreign bodies may be removed by enlarging the pars plana sclerotomy incision made for introducing the vitreous cutter, but larger intraocular foreign bodies may need to be removed through a corneoscleral incision. Complications of direct posterior segment open globe injury include fibrotic secondary cataract from residual lens matter, pupillary membranes including occlusio pupillae, retinal detachment, either tractional, rhegmatogenous or combined, epiretinal membranes, endophthalmitis, ciliary shutdown from cyclitic membranes, which may lead to hypotony and phthisis, and sympathetic ophthalmia, which is rare but a potentially devastating complication which may affect the non-injured eye also. Enucleation rather than evisceration of a severely traumatized eye with no visual potential, such as an auto-eviscerated eye, within 2 weeks of injury may reduce the risk of sympathetic ophthalmia, but this is a very rare event, and in all other cases, primary repair of an injured eye is strongly recommended. And after the onset of sympathetic ophthalmia, enucleation of the exciting or injured eye is not recommended, because in the long run, the visual acuity in the injured eye may actually be better of the two. Pathogenetic mechanisms for direct closed globe posterior segment trauma include co-injury, in which tissue damage occurs at the site of impact, contra co-injury, in which tissue damage occurs at a location opposite to the site of impact due to shock waves traveling through the vitreous cavity following the trauma and impacting on the eye wall diagonally opposite to the site of impact, and due to equatorial expansion as shown here in this diagram due to anteroposterior compression during the trauma. Commotio retinae, also known as Berlin's edema, is opacification of the deep retina, and being a contra co-injury, it occurs opposite to the site of impact. It appears as a zone of sheen-like retinal whitening as seen here in this clinical photograph, affecting the posterior pole and or the peripheral retina, and it typically appears some hours after the injury. The area affected can vary from small to extensive, and the severity can vary from subtle to marked whitening. When occurring in the posterior pole, it often spares the fovea as seen here in this photograph, and this is called the pseudochoroidal spot. Histopathology shows intracellular edema, chiefly of glial cells, and disruption of the photoreceptor outer segments, and vision may be impaired if the macula is affected to as low as 20/200. In mild to moderate cases, the whitening resolves over several days with restoration of normal vision, but in severe cases, visual disturbance may persist along with pigmentary alteration in the retinal pigment epithelium, retinal thinning, and macular hole formation from cystoid changes. In mild commotio retinae, OCT shows hyperreflectivity of the ellipsoid zone along with disappearance of the thin hyperreflective optical space, which can be discerned in the OCT image of a normal eye. With increasing severity of commotio retinae, defects appear in the cone outer segment tips, ellipsoid zone, and the external limiting membrane, and this OCT grading of severity has been shown to correspond with visual prognosis. Choroidal ruptures can be either direct or indirect. Direct choroidal ruptures are co-injuries occurring in the anterior retina at the site of impact, concentrate to the ora serrata, and are relatively rare. On the other hand, indirect choroidal ruptures, an example of which is seen here in this clinical photograph, are not uncommon and are contra co-injuries occurring in the posterior pole opposite to the site of impact. A choroidal rupture occurs due to rupture of the relatively inelastic Bruch membrane following equatorial expansion of the globe during a direct closed globe trauma. The choroidal rupture may be associated with injury to the adherent choriocapillaries, causing subretinal hemorrhage acutely, and retinal pigment epithelium, causing pigmentary alterations later. The retina is spared during a choroidal rupture because of its elasticity, and the sclera is spared because its strength allows it to withstand the injury. In contrast, in Sclopetaria, the retina also ruptures along with the choroid. Later, choroidal neovascularization can occur from the choriocapillaries at the margin of an indirect choroidal rupture, and this is very important to remember. Choroidal ruptures occur commonly even with mild ocular trauma in patients with angioid streaks who have a brittle and calcified Bruch membrane. Soon after the injury, the choroidal rupture may not be detectable because of the overlying subretinal hemorrhage and/or commotio retinae. Later, when the hemorrhage and edema resolve, the indirect choroidal rupture becomes visible and appears as a crescentic curvilinear grayish-white line in the posterior pole, as seen here in this clinical photograph, concentric with the margin of the optic disc. Visual acuity is impaired, and the extent of visual acuity impairment depends on whether the choroidal rupture is foveal or extrafoveal to as low as 20/200. Later, pigmentary changes, typically hyperpigmentation, develop in the margins of the choroidal rupture. As we have mentioned, macular neovascularization, either type 1 or type 2, may develop months to years later with further decrease in visual acuity. Soon after the trauma, fluorescent angiography may show blocked fluorescence from subretinal hemorrhage or leakage of dye from injured choriocapillaries at the margins of the choroidal rupture. Later in the disease process, early phase fluorescent angiogram shows hyperfluorescence within the choroidal rupture due to damage of choriocapillaries within the rupture, and late phase fluorescent angiogram shows hyperfluorescence from diffusion of dye from surrounding choriocapillaries, as seen here in this angiogram. Fluorescent angiography can also detect macular neovascularization. Indocyanin green angiography shows hypocyanescence both in early and late phases and can also detect macular neovascularization in an eye with choroidal rupture. Fundus autofluorescence shows hypoautofluorescence from the zone of rupture due to absence of retinal pigment epithelium within the rupture, as seen here in this photograph, often with hyperautofluorescence from the margins of the rupture due to RPE proliferation. But soon after the trauma, subretinal hemorrhage may also cause hypoautofluorescence. With OCT, two types of indirect choroidal ruptures have been distinguished. In type 1 indirect choroidal rupture, a small rupture occurs in RPE choriocapillaries along with protrusion of RPE choriocapillaries in a pyramidal or dome shape, as seen here in this OCT image. And in type 2 indirect choroidal rupture, there is a broad zone of rupture of RPE choriocapillaries and photoreceptors along with a posterior depression with posterior sliding of tissues into the choroidal defect. Histopathology shows break in the choroid along with fibroblastic proliferation within the rupture, which matures within 1 month, RPE hyperplasia at the margins of the rupture, atrophy of outer retinal layers overlying the rupture, and macular neovascularization from the margins of the choroidal rupture. Sometimes chorioretinal vascular anastomosis occurring through the rupture may also be found. This study found that proportion of foveal choroidal ruptures were higher than that of extrafoveal and extramacular choroidal ruptures, and 10% of eyes with choroidal ruptures develop macular neovascularization. Poor visual prognosis was associated with foveal ruptures, multiple ruptures, and poor visual acuity at baseline, and the risk of macular neovascularization was higher with larger choroidal ruptures, ruptures within the arcades, and older age. Treatment is of macular neovascularization occurring in an eye with choroidal rupture, usually with anti-VEGF injections, and patients with choroidal rupture should be made aware of reporting immediately if and when further deterioration of central vision occurs. Sclopetaria is also known as traumatic chorioretinal rupture, in which both the choroid and retina rupture at the same time due to the trauma. It occurs due to trauma with high velocity projectiles either impacting the globe or passing tangential to the globe and remaining lodged within the orbit. Sclopetaria is a co-injury that occurs in the sector of the fundus adjacent to the site of impact, but the rupture may extend posteriorly towards the macula with significant permanent visual loss. The affected zone shows a defect in the retina, retinal pigment epithelium, Bruch membrane, and choroid, each of which rupture and retract, leaving bare sclera which has enough strength to withstand the deformation at the time of the trauma. Initially, there can be associated intraocular hemorrhage, and the white bare sclera becomes visible ophthalmoscopically later with resolution of the hemorrhage. Still later, the margins of the affected area develop a jagged, scarred and pigmented appearance. The posterior vitreous cortex remains attached to the inner eye wall during and after the injury because of its elasticity. Subsequent detachment of the posterior vitreous cortex may lead to vitreous hemorrhage and or retinal detachment from a break distant from the zone of Sclopetaria. Retinal breaks can occur in a direct closed globe injury due to relative deformation of the eye wall and the posterior hyaloid at sites of strong vitreoretinal adhesion, chiefly at the vitreous base, but also at margins of lattice degenerations, fovea, and chorioretinal scars. Other causes of traumatic retinal breaks include contusion injury, and these traumatic retinal breaks are often more posterior and ragged in appearance. 10 to 20% of all regmatogenous retinal detachment patients give a history of ocular trauma, and factors suggesting trauma-induced RRD include unilateral vitreoretinal pathology, presence of other signs of ocular trauma, giant retinal tear and retinal dialysis, which we will be discussing next, young age, and interval between trauma and diagnosis of RRD of less than 2 years. The most common types of retinal breaks in traumatic RRDs are retinal dialysis and giant retinal tears. This is in contrast to non-traumatic RRDs, in which horseshoe tears and breaks at lattice degenerations are the most common, and this is important to remember. Traumatic retinal detachments typically occur in younger individuals, and the majority of regmatogenous retinal detachments in children are due to trauma. Onset of regmatogenous retinal detachment following trauma may be delayed in young individuals because of formed vitreous, which does not allow RRD to occur despite the presence of a retinal break, and this is very important to remember. Also, traumatic retinal detachments more commonly affects males as compared to females. In eyes with mediopacification, such as may occur from traumatic cataract or vitreous hemorrhage, UHGB scan is required to detect retinal detachment. And choice of surgical correction of a traumatic RRD, either scleral, buccal or vitrectomy, depends on the type of retinal break, as we will discuss, status of posterior vitreous cortex, whether detached or attached to the retina, associated injuries, and media clarity. Avulsed vitreous base refers to detachment of the vitreous base from its attachment to peripheral retina and the pars plana. Avulsed vitreous base may be isolated or may occur in association with retinal dialysis, which we will be discussing next. In the absence of a regmatogenous retinal detachment, a patient with an avulsed vitreous base may be asymptomatic or complain of floaters. On ophthalmoscopy, avulsed vitreous base appears as an arcuate ribbon-like grayish-white band elevated from the peripheral retina, as seen here in these two photographs, and tissue fragments from pars plana epithelium may remain attached to the structure. Avulsed vitreous base is pathognomonic of blunt ocular trauma, and this is important to remember. And presence of avulsed vitreous base in an eye should prompt search for other sequelae of blunt ocular trauma. Cryotherapy to the edges of the avulsed zone of the vitreous base may prevent occurrence of retinal breaks and retinal detachment. A retinal dialysis, as seen here in this clinical photograph, is a disinsertion or separation of the neurosensory retina from the pars plana at the ora serrata. Normally, at the ora serrata, the neurosensory retina is continuous with the non-pigmented ciliary epithelium of the pars plana. Blunt trauma is the most common cause of retinal dialysis, and retinal dialysis is said to occur due to contusive injury from the blunt trauma. Inferotemporal quadrant is the most common site of retinal dialysis, and this is important to remember. But retinal dialysis in supranosal quadrant is almost always due to a blunt ocular trauma. A patient with retinal dialysis may be either asymptomatic or may complain of floaters. Progression of retinal detachment from a retinal dialysis, although usually occurs slowly, posteriorly beyond the equator, will lead to corresponding visual field defects followed by loss of central vision. On ophthalmoscopy, a retinal dialysis appears as a large slit-like or fish-mouth tear of the retina at its insertion at the ora serrata, which opens up further on scleral depression, and the serrations of the ora serrata are less prominent within the retinal dialysis as compared to unaffected zones. As we have mentioned, the associated retinal detachment is usually localized with minimal elevation of the retina, as the attached posterior vitreous cortex does not induce vitreoretinal traction at the site of the retinal dialysis. So in retinal dialysis, the retinal detachment either remains stable or is very slowly progressive over time. If there is associated vitreous phase avulsion or posterior vitreous detachment, the retinal detachment is usually more extensive and elevated. Pigments may be found in the inferior vitreous cavity in an eye with a retinal dialysis. In the absence of retinal detachment, retinal dialysis can be treated either with cryotherapy or laser photocoagulation as prophylaxis of rhegmatogenous retinal detachment. But if rhegmatogenous retinal detachment is present, scleral buckling is required, which has a success rate of 90% in eyes with retinal dialysis. Vitrectomy is usually not indicated for retinal dialysis because of the attached posterior vitreous cortex, which leads to difficulty in inducing posterior vitreous detachment in these eyes. As we have mentioned, horseshoe retinal tears and operculated retinal breaks are uncommon forms of traumatic retinal breaks but can occur following trauma at sites of strong vitreoretinal adhesion, particularly in the peripheral retina, such as at margins of lattice degeneration or edges of choroidal scars. These retinal breaks occur due to trauma-induced vitreoretinal traction, and so the vitreous remains attached to the flap of an HST or the operculum of an operculated break. Patients may be asymptomatic or may complain of floaters and or photopsias. These patients require prophylaxis of rhegmatogenous retinal detachment with either laser or cryo, or treatment of rhegmatogenous retinal detachment with scleral buckling or vitrectomy. Giant retinal tears are circumferential retinal breaks 3 clock hours or more, that is 90 degrees or more in extent, typically at posterior vitreous base. Like traumatic HSTs and operculated breaks, giant retinal tears also occur due to trauma-induced vitreoretinal traction and so have associated posterior vitreous detachment, and may have radial posterior extensions of the break at its ends. The posterior edge of the GRT may be inverted posteriorly, as seen here in this clinical photograph, which may make it difficult to assess the status of the macula. GRTs are associated with a very high risk of rapidly progressing to retinal detachment and also a high incidence of proliferative vitreoretinopathy. GRTs need to be differentiated from retinal dialysis as management options are different. Retinal dialysis requires scleral buckling as we have discussed, but GRTs require vitrectomy. In GRTs, there is a strip of attached retina adjacent to the ora serrata and anterior to the GRT with a detached posterior vitreous cortex and a very high risk of retinal detachment. In retinal dialysis, the retinal break is at the ora serrata without a residual strip of attached retina adjacent to the ora with an attached posterior vitreous cortex, no inversion of the edge of the break, and a much lower risk of progression to retinal detachment. As we have mentioned, majority of retinal dialysis are traumatic, but most GRTs occur in eyes without a history of trauma. Majority of GRTs require vitrectomy with meticulous vitreous base shaving and silicone oil tamponade. Intraoperative use of heavy liquids such as perfluorocarbons to stabilize the giant retinal tear is an essential adjunct in the surgical repair of GRTs, particularly those with an inverted flap. Anatomical success, that is retinal reattachment, is achieved in 80 to 95% of eyes with GRT undergoing surgery, with at least half having visual improvement. Optic nerve avulsion refers to separation of the optic nerve from the retina with retraction of lamina cribrosa from the scleral rim. This separation can be either complete or incomplete. Optic nerve avulsion occurs when an object enters between the globe and the orbital valve or impacts directly and severely on the globe, causing sudden and severe relative displacement of the globe and the optic nerve, or sudden and severe rise in intraocular pressure. Clinical features of optic nerve avulsion include sudden drastic loss of vision, usually to no light perception, and on ophthalmoscopy, the optic nerve area appears excavated with overlying and surrounding hemorrhages, and the surrounding retina appears white due to associated central retinal artery occlusion. B-scan USG shows a hypoechoic zone on the scleral wall at the site of optic nerve insertion. Other ocular injuries which can occur from direct closed globe trauma include traumatic macular holes, which we have discussed in a previous session, intraocular hemorrhages such as intraretinal, subretinal and/or choroidal hemorrhages, which we will be discussing in a subsequent session, and serous retinal detachment from contusion-induced RPE damage or choroidal non-perfusion. The ocular trauma score, or OTS, is useful for prognosticating in both open globe and closed globe direct ocular injuries and has been found to be 77% accurate in predicting visual acuity 6 months after the trauma. The parameters considered in this scoring system are preoperative visual acuity, globe rupture, endophthalmitis, globe perforation, retinal detachment, and relative afferent pupillary defect, for each of which a raw score is given and the raw score sum is calculated. The raw score sums can be graded into OTS scores, and for each OTS scores, the probabilities of the visual acuity at 6 months following injury to lie within specified visual acuity ranges is given. Other prognostic factors which are not included in the OTS are the zone of rupture and extensive choroidal hemorrhage. Protective eyewear, ideally in the form of polycarbonate lenses, is recommended for individuals involved in certain occupations such as metalwork, handling machinery and power tools, and for individuals participating in certain kinds of sports. Protective eyewear is also recommended for patients who have already had an ocular trauma to protect both the injured and the fellow eye. To recap the salient points, ocular trauma can be either direct, in which the agent of injury comes in contact with the eye, or indirect, in which the site of injury is distant from the eye. Direct ocular trauma can be open globe or closed globe depending on the presence or absence of a full thickness defect in the eye wall, which is made up of the cornea and the sclera. Closed globe injuries can be contusion, in which there is no defect whatsoever in the eye wall and is caused by a blunt object. Lamellar laceration, in which there is a partial thickness defect in the eye wall and is caused by a sharp object, and superficial foreign bodies. Open globe injuries can be rupture, which is caused by a blunt object, or laceration, which is caused by a sharp object. Lacerations can be further classified as penetrating injury, in which there is presence of only an entrance wound in the eye wall, intraocular foreign body, and perforating injury, in which there is presence of both an entrance and an exit wound in the eye wall. Ruptures typically occur at zones of weaknesses in the eye wall, such as at the limbus, typically at the site of a previous surgical wound, or parallel and posterior to rectus muscle insertions, where the sclera is the thinnest. Zone of an open globe injury can be defined by the posteriormost extent of the full thickness defect in the eye wall, anterior and up to the limbus in zone 1 injury, up to 5 mm posterior to the limbus in zone 2 injury, and extension of the defect posterior to 5 mm from the limbus in zone 3 injury. Zone 3 open globe injuries are most likely to involve the retina with a much worse prognosis. Evaluation of a patient with eye trauma aims at determining whether the injury is open globe or closed globe, whether an intraocular foreign body might be present, and prognosticating visual recovery. History must include details regarding time and mechanism of injury and nature of the agent involved. According to the ocular trauma score system, factors related to a poor visual prognosis are poor presenting visual acuity, relative afferent pupillary defect, globe rupture, globe perforation, intraocular foreign body, retinal detachment, and endophthalmitis. Other factors which indicate a poor visual prognosis include posterior zone of injury and presence of choroidal hemorrhage. Ocular examination needs to be done without excessive pressure on the globe to avoid expulsion of intraocular contents. Tonometry, scleral depression, and ocular movement examination should be avoided in an open globe injury. An ocular evaluation should be done only after stabilization of vitals in a patient with polytrauma. Signs suggesting an open globe injury include diffuse and severe subconjunctival hemorrhage, abnormal or uneven anterior chamber depth, iris abnormalities including peaking and iris hole, rupture of anterior lens capsule, vitreous strands directed towards the region of suspected injury, prolapse of intraocular contents, intraocular foreign body, endophthalmitis, detection of an entrance wound, and low intraocular pressure. Inability to detect any or all of these signs does not rule out an open globe injury. Signs suggesting posterior segment open globe injury include deep anterior chamber, moderate to severe vitreous hemorrhage, and restricted ocular movements. Investigations include ultrasonography and CT scan to detect intraocular foreign body and to evaluate for associated injuries such as vitreous hemorrhage, retinal detachment, and choroidal hemorrhage. Ultrasonography needs to be done very carefully over closed eyelids and with copious amounts of ultrasound gel. On ultrasonography, an intraocular foreign body may show either a shadow or a ringing artifact posterior to itself. Magnetic resonance imaging must never be done unless a metallic intraocular foreign body can be definitively ruled out. But magnetic resonance imaging may be useful to detect non-radiopaque intraocular foreign body and to precisely delineate associated injuries. Documenting all clinical and diagnostic findings is very important for medico-legal purposes. Management principles of an open globe injury include stabilization of vitals if required, followed by urgent repair of the full thickness defect in the eye wall under general anesthesia. If an open globe injury is suspected and cannot be ruled out, exploration under general anesthesia is recommended, with repair during same session of a full thickness defect if detected. While the patient is awaiting surgery, a protective shield should be placed over the injured eye, tetanus toxoid administered, and systemic antibiotics initiated. After initial repair of the posterior segment open globe injury, a secondary surgical procedure is required within 5 to 14 days of the trauma for associated morbidities such as cataract, vitreous hemorrhage, intraocular foreign body, endophthalmitis, retinal detachment, and choroidal hemorrhage. Even in the absence of a serious posterior segment morbidity such as retinal detachment, intraocular foreign body, endophthalmitis, or choroidal hemorrhage, vitrectomy is recommended at this stage following a posterior segment open globe injury, as it has been shown to reduce the risk of retinal detachment and phthisis. Goals of this procedure include removal of mediopacities, removing vitreous incarcerated in the wound, and inducing a posterior vitreous detachment. An intraocular foreign body needs to be removed as early as possible during the initial or subsequent surgery, as it greatly increases the risk of endophthalmitis. Post-operative management considerations include visual rehabilitation of an injured eye with good visual potential, such as amblyopia therapy, use of protective eyewear, and psychological support. An intraocular foreign body can cause ocular morbidity due to direct damage during penetration into the eye, infection, and toxicity due to its chemical nature, typically by a metallic intraocular foreign body, particularly those made up of iron or copper. Intraocular foreign bodies made up of pure copper cause acute chalcosis, in which there is a fulminant intraocular inflammation which rapidly progresses to phthisis. Intraocular foreign bodies containing less than 85% copper cause chronic chalcosis characterized by cave-like rings in peripheral cornea, sunflower cataract, greenish or brownish aqueous and vitreous particles, and metallic flecks on the retina. Iron-containing intraocular foreign bodies cause siderosis characterized by nyctalopia, constricted visual fields, rust-like discoloration of the corneal stroma, iris pigmentation, mydriasis, brownish opacification of anterior lens capsule, pigmentary changes in the retina, attenuated retinal blood vessels, optic atrophy, and abnormalities on electroretinography, which is extinguished in well-established cases. During removal, an intraocular foreign body has to be completely mobilized from its adhesions with surrounding tissues before it is removed with forceps or magnet. Complications of posterior segment open globe injuries include secondary cataract, pupillary membranes, retinal detachment, endophthalmitis, phthisis, and sympathetic ophthalmia. Mechanisms of direct closed globe injuries include co-injury at the site of impact, contra co-injuries diagonally opposite to the site of impact, and sudden equatorial expansion with anteroposterior compression of the globe. Commotio retinae, also known as Berlin's edema, clinically appears as a shell-like whitish opacification of a sector of retina. Histopathology shows disruption of the photoreceptor outer segments. OCT of the affected zone shows hyperreflectivity of the ellipsoid zone and disruption of ellipsoid zone and external limiting membrane. Diminution of vision occurs if macular or fovea is affected, but in mild to moderate cases, visual recovery occurs over several days. Choroidal rupture occurs due to a break in the relatively inelastic Bruch membrane. Typically, it is initially associated with subretinal hemorrhage. Following resolution of the subretinal hemorrhage, the choroidal rupture becomes more distinctly visible and appears as a linear grayish-white lesion, often in the foveal or parafoveal region, concentric with the margin of the optic disc. Macular neovascularization may occur later following a choroidal rupture, which can be treated with anti-VEGF drugs to prevent further visual loss. Sclopetaria or chorioretinal rupture occurs due to direct impact on the globe or a high-velocity projectile entering the orbit adjacent to the globe. It occurs at the site of impact, in which both the choroid and the retina rupture and retract. Ophthalmoscopically, it appears as a white zone due to visibility of the bare sclera surrounded by pigmentary changes of the retracted choroid and retina. Peripheral retinal manifestations of closed lobe injury include avulsed vitreous base, retinal dialysis, giant retinal tears, horseshoe retinal tears, and retinal detachment. Avulsed vitreous base is detachment of the vitreous base from the peripheral retinal pars plana, which appears as a ribbon-like grayish-white membrane hanging in the anterior vitreous and is pathognomonic of blunt ocular trauma. Retinal dialysis is separation of the retina from the non-pigmented ciliary epithelium at the ora serrata, which most commonly occurs at inferotemporal quadrant followed by the supranuclear quadrant. Retinal dialysis can lead to slowly progressing retinal detachment and requires scleral buckling. Giant retinal tears are retinal breaks at posterior vitreous base extending for 3 clock hours or more and can rapidly progress to retinal detachment and require vitrectomy for repair. Optic nerve avulsion can occur due to severe increase in intraocular pressure or sudden rotation of the eye. It may be partial or complete. Clinical features include an excavation in the region of the optic disc with overlying and surrounding hemorrhages surrounded by white ischemic retina. Other posterior segment ocular manifestations of closed lobe injury include traumatic macular holes and intraocular hemorrhages. Protective eyewear, particularly with polycarbonate glasses, is recommended for individuals working in industrial environment and participating in sports where risk of injury to the eye is high, and also for individuals who have already sustained ocular trauma to protect both the injured and the fellow eye. Thank you for listening.